Hello, we begin our conversation today by referencing that very famous cliche that we're all familiar with. Health is wealth. Now, Mahatma Gandhi drives it home clearer. He says, and I quote, "It is health which is the real wealth and not pieces of gold and silver." Now, how true can those words be? Indeed, it is only the living that can enjoy any form of wealth. The physical and general well-being of a people is one of the main indicators of a country's level of development. And in its annual Human Development Report, that is the HDI, the United Nations draws on access to and quality of life, including life expectancy, infant and maternal mortality. Those are very critical tools of measuring a country's development. And on these indices, Nigeria has continued to, flag the red flag among global healthcare ranking index. For instance, between 1990 and 2015, Nigeria is said to have placed 140 position out of 195 countries, much lower than countries like Namibia, Gabon, Cape Verde, and Botswana. The diseases for which death rates were tracked include vaccine-preventable diseases such as tetanus, measles, maternal and neonatal disorders, several forms of treatable cancer, and heart diseases. Although the three tiers of government in Nigeria exercise responsibility over healthcare delivery, the concerns are many and varied, from access to quality and infrastructure. Now, all these combine to impede significant progress in the universal health coverage. But healthcare managers believe that the highest hurdle to achieving universal health coverage by the year 2030 remains equitable deployment of financial resources such that every Nigerian is reached, irrespective of location and work status. This is because how a health system is financed will to a large extent determine whether or not healthcare services available are within the reach of those who critically need them. And on this pillar again, Nigeria ranks low, and that's according to World Health Organization 2010 statistics. It says that out-of-pocket expenditure on health for Nigerians improved at 95.9%, only dropping quite recently from 100%. Now, there are different ways of healthcare financing in Nigeria. We have taxpayers' money, we have NHI, social insurance, and of course we have the out-of-pocket healthcare. Healthcare financing is one of the challenges bedeviling healthcare system in Nigeria. So today on Late Edition, we shall focus on this very critical area of concern, the healthcare sector. I am Claire Adelabu Abdul. Dr. Abubakar Bello holds a postgraduate degree in clinical oncology from the Medical University Varna in Bulgaria. He's currently head of department, HOD, at the Oncology and Radiotherapy Department of the National Hospital here in Abuja. Of course, he has extensive experience, like I said, in clinical consultancy, but he is a member of the American Society of Clinical Oncologists, European Society of Medical Oncology. He's also a member of the African Organization for Research and Training in cancer and also a member of the American Association for Cancer Research. I also have here with me Dr. Motunrayo Adetola. He is President, Canadian Association of Nigerian Physicians and Dentists, simply put, CANPAD, and also a member, an adjunct professor of family medicine at the University of Ottawa in Canada. Gentlemen professors, I'd like to thank you for finding time to join me in this conversation on the program.
Thank you for having me.
Where do I start? Both professors, very vast in issues of health, but let's begin by really diagnosing, this ailment. We know there are various aspects. People have talked about it. Why is it our healthcare system is so lowly rated? I mean, like I said, we trail behind countries, for instance, like Namibia, Gabon, Cape Verde. Let me start with, of course, our home base right now, Dr. Bello.
Thank you very much. When you look at the healthcare index for this country, basically, you will see that they are very low. And this is not perfect because over the years, our population has been increasing without commensurate budgetary allocation for healthcare. The World Health Organization has always insisted that third world countries like Nigeria should have at least 5% of its total budget assigned to healthcare. But I don't think in the last 20 years we have ever had anything near 4%. So, and that is grossly, even the 5% will be grossly inadequate considering the population that we have and the real needs that are on the ground. Take, for instance, I am an oncologist, so I treat cancers. Nigeria is not even ready to treat anything cancer because when you look at the facilities that are on the ground, in the last 20 years, we've not made any real giant stride. We've not succeeded in getting anything near what the World Health Organization is asking. I will give you an example of the radiotherapy machines. The requirement is like 100,000 per machine. So that means you will need nothing less than 180 radiotherapy machines. We had something like 7 machines for the whole country. And no 3 have ever worked at the same time. Only recently, about 4 months ago, was a state-of-the-art facility installed at the National Hospital, and it is the only one. You can imagine everybody is running to the National Hospital because it's the only facility. So you can see the machine is supposed to be treating like 30 to 35, 40 patients in a day. Currently we are treating over 80 patients.
So you have
over 100 patients on the waiting list.
Okay, you've touched 2 issues.
Yes.
You've touched 2 issues. One, of course, you've talked about, allocating budget allocation to the health sector, which is far below, WHO's recommendation. You've also, given us hints on the state of infrastructure.
So I'm trying.
Yes. Yes. I'd just like to pause you and get the input of Dr. Adetola. Over time we look at these, issues, these indices as, but we've gotten, a lot of people, a lot of reforms in the healthcare sector. We've, successive governments have made, quite a lot of, efforts to address some of these issues, and they still persist. Recently, you discover that a lot more people are now turning to traditional medicine. Is that a loss of confidence in the orthodox medicine, or is it a loss of confidence in the system?
There's a saying that when you fail to plan, you're obviously planning to fail, and that's what we've done here. So there's been successive failure to plan, and therefore a failure to follow up on anything, really. And therefore, we've seen a state of decay in whatever we had, if there was planning at some point, because obviously there was some planning at an earlier stage when our population was not as large as this. And as our population began to grow, we didn't build on existing infrastructure. And what we had Just like when I was on an earlier show yesterday, the president of the current sitting president of the NMA said in the medical school he went to, and I don't know which one, that the same facility that was there when he graduated 35 years ago are exactly the same one that are still there. Nothing has been added. 35 years and nothing new added.
But you know that's far from. I mean, it's unbelievable.
No, it is believable because I know that's the same thing that happened where I went to.
No, even worse.
Okay, and it probably was. And what has happened is now you can add whatever number of years since I graduated, and it's close to 35 years too, getting almost there. And that's what has happened. And what has happened over years is it's been used and it's been used. And what has happened is they've kept on repairing the same old equipment, and that's what is happening. You can replicate it across the country, and this is not the way it works elsewhere. New technology has come on stream, population has increased, and it cannot keep up. And so we've had charlatans all over the country rise up because people have been sick, will continue to be sick. We're like machines. We need maintenance. And
so whether it's infrastructure, whether it's expertise, personnel, or whatever,
they go hand in
hand. It all
hand.
Requires money.
Yes.
Absolutely.
And planning.
It all requires money.
And planning.
And planning.
Yes.
You know, planning how to use the money. We've seen efforts by successive governments to budget, plan or finance our healthcare, and that was why the NHIS was introduced. I mean, early 2023, over 20 years ago, if I'm not mistaken.
Yes.
So I'd just like us to look at this critical area of concern. Budgeting, financing.
Okay.
Because if we keep talking about the infrastructure, everything requires money, and the money is, obviously not there. So what does it mean when we talk about healthcare financing?
So I think that we're not putting the money where our mouth is. In all honesty, the money has always been grossly inadequate. And when we try to plan, we don't plan it properly. You know, the copy and paste thing that we're supposed to be doing, we don't do it well. I will take the NHIS, which is supposed to be one of the sources of financing healthcare. But you see, it's bedeviled by so many problems that at the end of the day, after almost 20 years, only about 1.5% of the population is captured. And the main aim is to have a universal health coverage. How do you get a universal health coverage if in 20 years you are only able to finance, in quotes, 1.5%? So where is the money coming from? That is what is key. Government is very clear, cannot do it alone. So people will have to find other means of financing healthcare. Otherwise, it's not going to work.
Can you break it down to us? What exactly, so that those who, when you talk of financing healthcare, what exactly are we what does it entail?
Okay, so if you talk of financing healthcare, it's the whole gamut of providing personnel, providing infrastructures, and providing facilities and services, most importantly. So all the components that are involved must be financed. If you have a structure, say you have a building, a hospital, you must have maintenance, you must have electricity, you must have water, and so on and so forth. That has to be financed. Most people are only relying on internally generated revenue to do most of these things because the budgets that are being made are never funded. I know that for sure. The institution I work with, the budget they gave last year was over a couple of billions of naira, but they got less than 200 million from the budget. So how are you expecting that they will pay for security, they will pay for water, they will pay for gardening, they will pay for so many other things, and to repair also equipment as well as provide new ones? So it doesn't work. So my thinking is we really need to sit down and revisit how do we finance it. I remember at a point the previous NHIS boss was talking about taxing every Nigerian maybe 200 naira. So if you multiply that, 200 naira for 180 million people, you are looking at a couple of billions that you can actually use to provide infrastructure as well as equipment. But at the same time, we must also stop the brain drain. It's one of them. You know, stop the brain drain and invite our expertise from abroad to come and look at how they can actually move forward the training of people. Most of the best brains are not here. That's exactly what happened in India. They invited most of their people, sat down with them and financed them. They are private hospitals.
Yes, so we will get to the, you know, what models and how we can help, you know,
a very good example of, since we're having a conversation, a very good example of what you just said was that hospital that was built in 2015 for 41 billion naira in one of the southeastern states that closed down in October of last year. It cost that state 41 billion naira. I shall leave the state unmentioned, but everybody knows, you know, a few weeks after it was commissioned, the governor of the state who commissioned the project flew out for some undisclosed ailments himself. Now, if there was adequate planning, after spending 41 billion naira, there should have been built into that, you know, how you were going to sustain that hospital, how it was going to be run. It wasn't even connected to the grid.
We are working on the WHO framework of, Dr. Bello, you said 5%? Is it 5% of 15?
Minimum. Yeah.
Minimum of 5%, but in stipulating that percentage,
they were just suggesting to us, by the way. They were not even recommending. It was just a suggestion.
Please, that minimum.
I hope you know. That's just a minimum. You know, it's an advice. Yes. They're not saying we shouldn't spend. Let me give you an example. This 5% thing. In fact, if I hear it one more time, I feel like puking. The US spends 16% of its GDP on health. And you can replicate. You can look at the same figure for Canada, the United Kingdom, 16% for every.
Is US a fair, you know, comparison for?
No. So just look at it. So we should be looking at about, you know, Newfoundland, which is a province of Canada where I used to work, spends 45 cents of every dollar on health or health related issues. 45 cents. That's 45% on health related issues. That's how much people value their health. So the point is, do we value our health 5%? Oh, sorry. In our case, it's obviously not 5%. It's 3%.
Yes.
That's how valuable our health is in Nigeria. That's how much we're able to throw at it. And remember, we say health is wealth. Is our health really our wealth? That we're willing to spend only 3 naira out of our every 100 naira. That's what we're doing at the moment.
You know what baffles me when we talk about this is that all the practitioners, health managers, know about this. They know about the essence and importance of budgeting, you know, good budgeting. But we're still talking about less than 3%.
And remember, that's how much they're even budgeting. That doesn't mean that's how much actually goes into it.
Dr. Bello, can you give us an insight into what you think might be happening in the psyche of our health managers?
The sincere truth is political will. You understand? There was a bill that was signed by the previous administration that 2 to 3% of the national growth should be allocated to health. That has not been implemented up till today. So it's a political will, and as long as people that can afford and people that are in position of leadership will jet out anytime they are ill, nothing is going to happen. That is the honest truth. We have to say the truth to ourselves. If everyone is going to stay here and get treated here, then you will be sure that it will be provided.
It will.
Look at the National Hospital. It's 20 years old now. No such thing has been replicated. It was meant to be a hospital for children, women and children. The men came and hijacked it and said, let it be National Hospital. And we said, oh, okay, let's do this. And nothing has changed. The budgetary allocation has dwindled over the years.
Over time.
It was under the presidency, so they were getting subvention directly from the presidency. Many people came and made so much noise, no, politically this and that. They said it should be under the Ministry of Health. Okay, it is under the Ministry of Health. The Ministry of Health has over another 40 teaching hospitals and federal medical centers to look after. And where is the budget? So the national hospital started going down because there is no budget.
Talking about budget, I'd just like for both of you to, you know, talk to me about our healthcare, you know, financing. obviously it doesn't, reflect that Nigerians are getting the best services.
They're not. So I was looking at the recent budgets, and I'm not talking about the recurrent expenditure, because that's just money that goes into paying salaries and all that. So that doesn't really tell you how much. So every time you look at the budget, you see all these billion, trillion dollar, naira or whatever. Don't look at it. What you should be looking at is the capital, because that's what tells you what's going on, what's likely to happen. So if you look at the health budget for this year, it says there is 71 billion naira that's going into capital expenditure. That's how much is going to happen in terms of maybe acquiring new equipments or
So
maybe building
it into dollars, because they are importing most of it.
Oh no! This time around, this time around, I will leave it in naira. I'm not gonna convert. I'm not going. No, I know. But the point I want to make. No, the point I want to make. I want to make it in naira. So let's leave it in naira. 71 billion naira is going to go into capital expenditure. Now remember, rich Nigerians spend. This is the conservative value is anything from 1.5 to $2 billion every year. This guy's going to India, South Africa, Germany, US, Canada. I have to mention that last. And every year they spend $2 billion in healthcare tourism.
Capital flight.
Yes.
That's capital flight. That's money that could have been spent here to develop healthcare, research, training, equipment, and all of that. If you convert that into naira, that's 700 billion naira. Easy. We're spending 71 billion naira this year, capital. We're taking out 700 billion naira outside. We're only spending 1% on our health here this year, and we're taking, and that's 1% of how much we're taking out. Does that make sense?
Dr. Bello, again, if you look at the population of those who pay for healthcare services, like UN said, 95% pay out of pocket.
Yeah.
Might that be the main source of our financing?
Yeah.
Well, that's what
right
it means, and that is one of the key areas that people keep dying, and they are going back to traditional healers because they can't afford to pay for services. If you have a cancer and you need a couple of millions, where do you get it when the minimum wage is still 18,000? So my thinking is, look, government alone can't do it, but government as a policy maker must unbundle the healthcare, healthcare services all over the country. Let them provide incentives for investors to come into this country. There's a hospital in Lagos that wanted to bring in radiotherapy machine, but it took them 4 years or more to be able to get somewhere that they are making progress. So if you will spend 4 years, 5 years in providing one facility, I mean, it means that there are so many bureaucratic bottlenecks. So if they can unbundle that, that's the first thing to do. Make it easy. Encourage financiers to give professionals and anybody that wants to provide services in the healthcare a tax relief, a very work with the banks to get very low interest rates.
Low interest rates.
So that we can have facilities. All the hospitals that our people are going into, to India, to Egypt, to Canada, and now even to Kenya, are private hospitals. The Aga Khan Hospital in Nairobi is such a small hospital, but it's privately driven, and they have budgets, and Nigerians are now going there. But we cannot even replicate it here. I had reason to discuss with the CEO of Aga Khan. I said, how do you do it? He said, well, government is providing him with a lot of tax relief, and when they are importing things, they don't get a lot of custom duties, and so on, and then there is also tax relief when they are also providing services, and so on. So if you can do that, that is a way to encourage investors to come into Nigeria and invest in health.
Okay, we will look at the merits in tax relief and the unbundling that you've suggested, whether, you know, in their own way they will bring down the cost of you know, healthcare services for those who really need them. But briefly, Dr. Adetola, obviously there's no equity in the model that we're adopting, which is, for me, is based on your ability to pay, because most people now, you know, seek services, you know, go to the private sector, you know, to get their healthcare services, and that depends on your pocket.
Yeah.
There's no equity in that, is there?
No, there is none whatsoever. More like people are not really there's no, the access to health is really not there.
And these are the people, by the way, these are the people who also pay their taxes.
Yeah, they are.
The same taxes that government uses to fund.
So another thing we can do, just like you suggested earlier, is if the problem, and I don't know what the pulse of the government looks like, if the problem is that there is not enough funds, like my colleague mentioned earlier on, why can't the government say, hey, another 1 or 2% in VAT, and maybe 1%, you know, another 0.5 or 1% in corporate tax, dedicated specifically? This one goes only to health. They did it in Ghana, and they've done it in other countries. You know, this top up goes specifically for health development. It can even be for a period of time, maybe for the next 10 years. You know, so that we can it can help to build our healthcare infrastructure.
Okay, I just pause you. I just pause you for a while.
Yeah.
We'll just go on a short break, and when we come back, we'll be looking at ways in which, of course, we can help to reduce, you know, the out-of-pocket payments, you know, for health services, such that a whole lot of Nigerians, you know, can be accommodated and covered, and you know, in such a way that we can achieve our universal health coverage by 2030. Stay with us. This is Late Edition.
The Nigerian Television Authority News 24 channel, your dependable all-round news station, offering you world-class news programs, documentaries, spotlights, promos, and information highlights. Take advantage of our network reach and advertise your interest, goods, and services with us. NTA News 24, first among equals with digital broadcasting. You can reach us on channels 21 terrestrial TV and channel 101 on the StarTimes platform. Join us today.
Hello and welcome back. This is Late Edition, if you've just joined in, and I have with me President of the Canadian Association of Nigerian Physicians and Dentists, CANPAD. He's also an adjunct professor of family medicine, University of Ottawa. That's Dr. Motunrayo Adetola. He's also here. Dr. Abubakar Bello is a familiar face with us. He's a head of HOD, the Oncology and Radiotherapy Department at the National Hospital. Gentlemen, thank you once again for joining me for this conversation. Let's begin to look at ways in which we can help, you know, make healthcare services affordable for everybody. National Health Insurance Scheme obviously has not been able to capture a whole lot of people. You talked about under 1.5%.
So the national...
You talked of unbundling.
Yes.
When you talk of unbundling, a lot of people, it sends, you know, shivers down our spines. If you unbundle, there are a lot of consequences. So...
Yeah, well, what I meant by unbundling sincerely is that you should have some kind of liberality so that people that really want to invest can actually have their investment secured, and they know that there will not be too many bureaucratic bottlenecks.
Isn't that being done? Presently, you find a lot of public collaborations?
Well, we haven't seen the real ones, actually. We haven't seen the real ones. You cannot say that there is one single comprehensive cancer center in this country. Not one. Both public and private. There is not one. And so where is the unbundling? It takes a long time because of bureaucracy to get even one machine across into Nigeria. And you are talking about how we can reduce the out-of-pocket. Let's look at the NHIS and the way it is established. It's part of the thing that needs to be unbundled. The National Assembly should look at that act and sincerely remove all the middlemen. That is the HMOs. That is the honest truth. HMOs receive 5 billion as administrative fee every year. That 5 billion can go for treatment of cancer patients in this country. There are so many. Let the NHIS pay the hospitals directly, and let the hospitals have a kind of HMOs, so that there will be no bureaucratic bottlenecks. Before you get, a lot of hospitals are not interested in getting into the NHIS thing because they don't get paid. The fee for services are not always paid because they are not there. So there is so much. That money can actually be used to finance more than 5%. Because it happened in Kenya again. Kenya had HMOs, the same model that we were doing, but they found that only 5% of their population was covered. So they removed the HMOs. And today, as I'm talking to you, the coverage in Kenya is almost 55%. And every cancer patient that is supposed to receive targeted therapies that are so expensive are covered free of charge for every Kenyan. We can do the same thing. That money that is being invested, even though it's only federal civil servants, could actually be used for that. And then the state government should be compelled to key in also and form their own health insurance. And also the local governments, because everybody is involved. This issue that primary health care is being taken care of by the local government is not happening. It's still the federal government that is funding the local government and the state government.
And that brings me to my next question, Dr. Adetola, because we have as much problem with accessing secondary health care, tertiary health care, as much as we have with accessing primary health care, which is the root of, you know, all the problems we have. So how can we, again, unbundle NHIS or reform NHIS so that it can accommodate a whole lot of people?
It's because the primary problem there is because there's no structure. There is no such thing. We really don't have primary health care, secondary health care, tertiary. People are sick and they just go wherever. And first of all, the primary health care is really non-existent. You go to these things we call primary health care. You get there, there is no doctor, there is no nurse. You probably have somebody there or somebody, I don't know what names they call them. They're not really nurses. They
auxiliary nurses.
The auxiliary nurses will actually be good sometimes. There are some other training less than that, and they are the only ones, and you'll be lucky to get those.
In local parlance, we call them muiwa.
And you will be lucky to even get some of those, and these are people who really got no training, but somebody has taught them how to give injections, and that gives them some leverage there somewhere. And really, that's not it. The ideal thing will be to at least get somebody with a registered nurse training who is a nurse practitioner, which is actually another level of training, who can provide primary care. Because a well-trained primary care practitioner should be able to take care of 80–85% of primary care needs. Diagnose hypertension, manage hypertension, manage your malaria, your pneumonia, that kind of stuff at the community level. So that by the time that is well dealt with, the hospital, which are your secondary care, tertiary care, should be free to deal with secondary care issues and not be burdened. But what is happening is there is no referral system. People just walking into the National Hospital or the UCH or Lutz or wherever.
So what lessons can we draw from you? So both of you have been abroad. So what lessons can we, let's begin with at that primary level where there is no structure.
So the lesson is we have to actually first build from the bottom up. Right now, we're not building from anywhere.
And enforce it.
We enforce it.
Yes.
We have to enforce it, but enforcing means we have to first of all build that structure. Because right now,
who builds it?
It's the function of the local governments, they say, to build the primary care. So I think the federal government has to make sure that the local, because they are the apex, and they are the ones, they hold the purse string. They have to make sure that the local governments do their function of making sure that the local governments do their primary function. And then for those who are a little bit rich, they should have their primary care physician. The regulatory authority, the physicians, for instance, have empowered a lot of doctors now. There are now training for GPs you know, to do the work of primary care physicians. The postgraduate colleges are now churning out doctors with added competencies in family medicine. So at least on the side of doctors, we're doing our own bits, you know, to train out doctors with added competencies to do the work of a primary care physician. I don't know what the nurses are doing on their own side. Just to add to that, because we don't have enough doctors to start with. That is the truth. There are only 42,000 doctors in this country. Total. When we need about 300,000 of them.
Yes, because so I have to rush both of you now. Yes, yeah. What do you have to say?
Yes, so he has mentioned something that is very critical, the referral system that is not obtained in this country. You know, you have no business really in an ideal situation for somebody that has seen a lump for the first time going to the national hospital. Okay? Because that is a tertiary institution. That's an affects hospital. You should go to your GP and said, look, examine me. I have a lump. And then the GP will now examine and said, okay, this is really a lump. You need to do a mammogram. And then with the mammogram, he now sent to the secondary, maybe a general hospital like Asokoro, Maitama, and then they
if there is a need.
If there is a need. And then they said, okay, we're going to take it out. When they take it out, they send it for pathology at any of the general hospitals. When they confirm that, yes, this is cancerous, now it's no longer their business. They now send to National Hospital, which is the tertiary institution. So if this kind of referral process is being followed, a lot of the people that go to National Hospital will not be there. But if you are a big shot, you will just call one doctor and said, I have a headache.
And then there'll be wider access.
Yes,
and then
there will be wider access.
Yes.
And everybody will do it.
It blocks every other person from getting the access they should get.
Let me hit at a very important issue, which is of course it's trending now. The fact that most of our programs and policies, that's healthcare programs and policies, are donor funded, and we know that HIV, for instance, tuberculosis, for instance, malaria, poliomyelitis, these are all programs,
funded internationally by donors internationally. How come we don't have donors here on the ground?
Now there's a challenge because
we don't have Nigerians donating.
Some of them are pulling out, and
Yes.
you health managers are saying, look, we can take ownership of these programs.
Yeah.
Do we really have the financial muscle, to take over the ownership of these
We
programs?
have the financial muscle, but whether we have the political will to take over and the sincerity of purpose, the commitment to take over is another question. We have the financial muscle.
Where do we get the fund? Where would
the money?
They
they found $40 million in one small house in
somewhere.
Lagos.
And yesterday I read that the US is going to repatriate $500 million. I mean, there is this money from all over the place.
And $40 million will provide 10 radiotherapy centers in Nigeria.
But we must be structured.
More than that,
you
we
talk
have,
about structure.
for example.
The financing model must be structured.
Let's put it this way.
Absolutely.
If God were to drop $10 trillion on us, just drop it from heaven like this, and we don't have a plan on how to spend it, it will still be useless.
Yes.
The point is we have to find a plan for how we're going to spend what we have.
What plans are you suggesting? What is a desirable plan that fits?
We're not going to. We're not going to.
Let me start
we're not
from you
going.
because
We're not going to. We're not going to reinvent the wheel. The wheel has been invented already. So we're not asking for. Let's do new things here. We're not even planning to go to space here. Let's do basic things. Start primary care and do it like it's been done elsewhere. Put at the minimum nurses there. If you can't get doctors, because doctors are not minted in a day. It takes 6, 7, 8 years to train doctors. We have nurses. Put them in, make sure there is at least a nurse in primary health care to help everyone. And in the meantime, start working towards putting doctors along with them. That's the place to start. Every local government clinic should have that as a long-term plan.
Healthcare centers.
Healthcare center should have that, and for those who can afford it, they should have their own family doctor, and start working towards having an EMR, electronic medical record. This is the trend everywhere in the world right now, so that there is adequate documentation and the referral process is put into place.
Are you taking cognizance of the fact that those in the rural areas are also part of?
They are all on Facebook. They're all on Facebook.
Most
I see
of
them.
And in truth, you know, the Federal Ministry of Health is taking steps in getting the plans ready. But whether they will be implemented is another ballgame. We just recently launched the National Cancer Control Plan for the next 5 years. And in it, it is very clear what we are expected to do from the primary healthcare, secondary and tertiary, in terms of diagnostics, in terms of treatment, in terms of palliative care and so on. We even costed everything. That will cost about 79 billion to implement. Now, will government say, okay, we're going to give 79 billion in the next 5 years so that we will see that these things are implemented? If it's done for everything, for not just cancer, for cardiovascular diseases and so on and so forth, you will have the plan. But the issue has always been consistently that we just need to do something in a hurry.
Yeah.
The Ebola came and everybody realized that Ebola is going to kill everyone. And we acted on it.
Quickly.
The Americans had to come and learn from us. How did you do it? So it is not that we cannot do it. There must be political will, sincerity of purpose, and every other thing will take its course.
Yeah.
But we are not so sincere about what we are doing. I keep saying, let's privatize the tertiary institutions, and you'll be shocked how they will work. They will work because somebody is going to invest his money.
Will privatization, because we've had experience of privatization of other sectors, and we know it's not
working.
a very pleasant experience. Now, privatizing healthcare. Hello, gentlemen.
Well, okay, let's put it this way. I also believe. I
totally agree with you.
Yes,
if you will be afraid
Yeah.
quickly to privatize, you have to strengthen certain things. The insurance, like I said, the national health insurance has to be strengthened and made in such a way that they are dealing directly with the hospitals. And at that point, you know that you are getting services, then you privatize, then you will have all the facilities that you are looking for. If you don't privatize everyone, let every state of this country have a private apex hospital that is in collaboration with government. They will provide oversight function. They will make sure that everybody is attended to, especially emergencies.
You're advocating outright privatization. Dr. Adetola, is that what you also suggest, or is it a kind of public-private,
Well,
of course, government has some form of...
Well, I'm not going to pretend I'm a healthcare economist here, but there certainly is there's an argument to be made in some degree of privatization, whether it's done by people in the private sector or governments. But look at it this way. I'm just looking at the education sector. Up to a certain point in time, if you look at our tertiary universities here, there was strikes, ASU, NASU, and every association within the university were always going on strike. And if you entered for a 4-year degree, you will be lucky if you finished in 8 years. And then the private universities came on, and those kids who are rich enough to go into them will finish at 4 years. And now,
is the situation better now?
No. At least for those who go into private universities, they will finish in 4 years. Now, I don't know what the quality of what they are getting in there, but at least you go for 4 years, you finish in 4 years. People who are going into those private universities are finishing.
We're talking about life here.
No. Well, we're going to apply it in the second.
Yes, we're talking about life here.
But there's the
people that travel out of this country go to private hospitals and they pay. And it is working. Why can it not?
So why can it not work in the hospitals? So now look at it this way. A lot of these organizations that have these private universities are churches and mosques, religious organizations. Why can't these same churches and mosques, religious organizations and private organizations start even at a small level, 100-bed hospital, but top quality?
Let's look at
go into the same institution, into the same business of health this time around, and do the same for us, and collaborate with those of us in diaspora, for instance, and with the skill, we can come and work with them. We've been saying this for a long time.
Right now, gentlemen, I don't know, this is my statistics, I know that a lot of the healthcare services right now is provided by the private sector.
And it is true. But these are mostly stand-alone private hospitals.
Yeah, and that's
so there are so many things that they cannot provide. They say they provide healthcare. What kind of healthcare are we talking of? Are you talking of a comprehensive standalone hospital?
And that's not true.
That is not. This is one-man show that is going on. I am a doctor. I provide
medicine,
oncology
surgery,
care, and
ONG,
I have a private
everything.
practice.
No,
and
that's not care.
We are not talking of this.
You have some form of collaborations from the diasporans, physicians in the diaspora, coming back here, rendering some form of services.
It's too small right now.
It's too small, and they are mostly coming to teach.
Yeah, it's too small.
And then share research work and so on. But
so what Dr. Abel, I'm sorry.
You have 5,000
Nigerian
Nigerian doctors in the UK.
What's the
6,000 in the US,
of
1,005 in Canada, and then you have, it's like a drop in the ocean, what you're seeing right now. There can be much more. If we want to see what you've seen in India, for instance, it's too small. There are just so many Nigerian doctors that are at the top of their grade, wherever they are, that can make a huge impact. And we need large inputs.
I just want to ask you, because you are the president of the Canadian Association of Nigerian Physicians and Dentists. We're talking about making healthcare, quality healthcare, affordable. That's the objective of this discussion.
Yeah.
What's the contribution of Nigerian physicians, of your association, in this regard?
Well, one thing I can tell you, we're late entrants into the game. Our American colleagues and the British have been there ahead of us. Just last month, our American colleagues did a mission where they brought 40 doctors to Enugu. And they did surgeries and consultations and all of that. And that was very successful. We're working on a draft project with all the diaspora organizations together on how to ensure this, because there are also problems we're having, getting our colleagues registered. Because you can't just come here and practice. We have to jump through some hoops with the medical council to get license, because they say we left, you didn't tell us. So therefore you need. So what's our contribution? We want to come back here and collaborate with our colleagues and work together, and learn. There are things to learn from them. I don't know anything about Ebola anymore, and malaria has changed since I left. So there are things for me to learn, and by the same token, they have lots of things to also learn from us. The skills we have been exposed to. So those are things we can work together, transfer skills. Those are things for us to learn. So we want to exchange ideas that way and work collaboratively.
Dr. Bello, a lot of people believe that these, diasporan physicians that are coming home now, to provide assistance, basically see healthcare provision as a business, strictly from the business perspective. And that will now put a question mark on the issue of affordability.
Well, you see, it's a function of semantics. Healthcare has always been a business, even now as it were, because somebody has to pay for the services. Somebody has to provide the equipment. Somebody has to provide for drugs. Nobody goes to National Hospital and is treated free of charge. So it's still a business. Let's not pretend. The truth of the matter is this. We must be able to be dispassionate when we talk about healthcare, that it is health. So who is paying for it? There is no free meal. If they are coming to provide top services, then that top service should be paid for. It is as simple as that. You will be shocked to realize that the money Nigerians take, you just mentioned it.
$2 billion. Somebody's paying.
If I tell a Nigerian in National Hospital, it will cost you 2 million naira to treat your cancer, he's out. He will say, this guy is crazy. He wants to spend all my fortune. But the moment he's going to India, he will pay for air ticket, he will pay for accommodation, he will spend 4 million.
And he will take somebody along.
He will take somebody along. He will come back here and say, I got the best. But he will not tell you that he has spent 4 million naira. He will not. So we are not being sincere. It's a business. There is no two ways about it. The Indians are making money. It's their business. That's what they are doing. But what we need to do is to have policies that will protect the patients
from abuse.
From abuse, exactly. If we have that in line,
exploitation,
believe me, and that's why I keep saying this privatization thing. Because if I invest my money in a hospital, I will make sure that I'm recouping that money. That means there must be proper services. That means I must provide the equipment. That means the person will see that, yes, I'm happy, not that he is compelled to go to that hospital. Most people that you see in government hospitals have no other options. And you will see that, I'm sorry to say, some of my colleagues will be so rude to the patient. and nurses and everybody else. And he will have no option than to stay because he has no option.
Because he's sick.
If it's private, you can't do that. The manager will send you away right there and get someone else.
But okay, how can those people be made to, be empowered to be able to afford or, pay for the services when eventually, and if eventually, the system is privatized? Because we talk about models like community-based financing, community financing. I don't know. Maybe you need to explain.
Well, first of all, knowledge is power. One of the reasons people are able to do, like maybe colleagues be rude and all that, is because they also know a lot of our people are not informed. If people are knowledgeable and informed, you know that if somebody is rude to you, there are regulatory authorities to which you can take this kind of cases.
No, when you're down,
no, I know. Yeah, well, you hope that one day you get better and you can report. You can report to the hospital management itself. No.
Let's not even go there.
Well, in time, people are not always going to be down. In time, these things are. Look, well, at least in the first world. These things are taken up.
Dr. Bello, how many people have been reported to you, for instance? Have you received any reports? Have you taken any action?
It's such a difficult thing.
I know.
There's a disconnect. There's a management. There are the laborers. There are the ones that do the job.
I know. I get it.
So you understand.
But this is a societal
thing here.
This is a societal
thing. That's why I
thing.
said let's put policies.
No, I get it. Look, I arrived at the airport the other day, and first of all, you get it right from the airport. I go out. First of all, you can't even be received by your relatives. You get to the airport and it's like you get out, no standing, no look, and then the places where people are supposed to receive you, there is no roof there. If it rains, God save your people who came to welcome you at the airport. And there are military policemen all over the place harassing everybody. This is the country we live in. So you get it at the airport, you get it in the hospital, you get it everywhere. This is our community. We have to do a lot of things. So the hospital is a reflection of our very community. So you're not going to start this reform in the hospital.
Yeah.
It's going to start everywhere.
We're still dealing with the issues of, you take your sick relative or, spouse to the hospital. You probably don't have money to pay, and the doctors insist, or the health managers insist that you have to pay. This is at variance with your ethics.
But again, this is what the government can do. Look, even in the US, for instance, where people have to pay for healthcare and insurance, but in an emergency where your life is at stake, you should not be refused health. In the US, you cannot be refused. Doesn't matter whether you have money or not, and it should be the same here.
It is the same because our health
it should be the same because your life is at stake.
Is that happening? It's not happening.
It is happening, but the truth of the matter is, you see, as typical Nigerians, sometimes we take advantage of it. Somebody will walk in with an emergency and he's been taken care of. Then he is wheeled to the ward and he stays there. And the next thing is he will start saying that he has no money to pay and he cannot walk out when the emergency is out of the way. Because there are two critical things. I'll give you an example. Somebody walks in bleeding. A woman walks in bleeding, she has cancer of the cervix. It's an emergency. You have to stop the bleeding or else she will die. So you rush her to the radiotherapy, get the radiotherapy done, and then admit her so that the bleeding stops. After a couple of days, you've done the radiation and bleeding has stopped. You want to start treatment. No dying. You will write a prescription. They send it to the pharmacy. The pharmacy will cost it. And okay, you will sign that this prescription, I will sign for it, later on they will pay. You start treatment, first course. The patient is there 1 month, 2 months. He is not paid a dime.
So what will be the fate of this person, doctor?
So
what should
be
the fate of this person?
So there is nothing that government has put in place or any societal organization that has put in place to look after those indigent patients.
Now she's no longer
knowing that most Nigerians, 79% of Nigerians live on less than $1 a day. And they need to get this thing. So sometimes some hospitals really don't accept certain patients they will keep referring them, go to another hospital. No, we don't have facility here. It's not necessarily that they cannot handle it.
How can this issue be addressed? Because we just have that.
We must have what is called catastrophic health funds, okay? And then this will be managed by honest people, sincere people, people of integrity, that will go to hospitals and say, we're giving this money, we'll come and check how many people have you taken care of, and then we'll make sure that it is done properly. If you don't have that, the hospital will keep going down. Their IGR, the internally generated fund, is so small. They will close down. They will close down. They will be so indebted to contractors, because these drugs sometimes are bought on contract. They have not paid. They are looking for patients that will pay. Then they will now pay back the contractor.
Okay, Dr. Titola, what can we draw from?
Well, the other way is to adopt models that is different from maybe the NHIs, maybe like the British or the Canadian, where it's a societal contract. Like everybody should be covered, whether you're rich, whether you're poor, whether you can pay or not pay. It's something the government can look at. And it's like, you're a Nigerian, you're sick, we may have to pay a lot more tax to do that. It's about looking at what our beliefs are as a society, and say we really value health and we want everybody to be covered. It's something we can look at. That way, we may decide we're not going to pay for things like root canals. We're not paying for those kind of things. We're not paying for fancy implantation of lens. But if you have cancer, we'll take care of it. If you have appendix, we'll take care of it. So it's going to cost a bit more money, but we can look at those kind of things, and that way we know you are covered.
Everybody's why can't we take 1% of the value-added tax and appropriate it for those kind of patients?
Yeah.
Dr. Abubakar Bello, Head of Department Oncology and Radiotherapy Department at the National Hospital, I'd like to thank you very much for your thoughts. And I'd also like to thank Dr. Motunrayo Adetola. I'm sure you know why I love that name, Motunrayo. Outside here, you explain what that means to Dr. Bello. President, Canadian Association of Nigerian Physicians and Dentists, and of course, Adjunct Professor of Family Medicine, University of Ottawa, Canada. Thank you for coming. And that's been our program for today, late edition. We've looked at healthcare financing and how we can reduce the out-of-pocket payment for every Nigerian, so that we can cover, make significant progress with our universal health care coverage by the year 2030. I am Claire Delabo Abdurrazak. I'll see you again. Bye-bye.